So welcome everybody, thank you for coming. And we have quite a bit to get through, a lot to discuss, so we're going to do brief introductions and then get right into it. So I'm Jessica Cantor, I'm a journalist and I cover human rights and social impact. I've been covering mental health and behavioral health for about 10 years. And if we want to go down the line and do brief introductions.
Thank you. I'm Jessica Johnson. I'm a director of complex health policy and strategy at CareSource. CareSource is a national nonprofit health plan. My background is a licensed clinician in the state of Ohio, primarily in substance use disorder, and I'm an individual with lived experience with substance use disorder as well.
Hi everyone, great to be with you. I'm Stephanie Strong, the founder and CEO of Boulder Care, and Boulder is a telehealth provider of treatment and long-term support for patients overcoming substance use disorders, including opioid and alcohol use disorder. We partner with health plans and particularly focus on Medicaid patients, so policy is very much a part of what we do. And in my previous work, I also did some work in DC on healthcare reform and an integration of medical and behavioral health at Duke Health System.
Nick Mercadante, founder and CEO of Pursue Care. We are a virtual clinic for substance use disorder treatment. We're focused predominantly in rural areas, trying to increase access and quality of care. And we work collaboratively with health systems, hospitals, community health to try to bring our care right into the community. Reformed healthcare attorney at this point. So don't ask me to quote the exact regulation. I'll do my best.
And I'm John Snook. I'm the Chief Policy Officer at the Meadows Mental Health Policy Institute. You have likely seen a few of our folks. We've got a lot of folks here hosting sessions, so happy to be here.
Hi everyone, welcome. Thanks for coming. I'm Angie Callistra. I train the interdisciplinary workforce to treat co-occurring disorders. I spend a lot of time focused on primary care doctors. I'm also an advisor to our drug and alcohol secretary in Pennsylvania and our governor, Josh Shapiro, on substance use disorder issues. It's great to be here.
Wonderful, thank you everybody. So to start us off, we are going to be addressing the elephant in the room, pun intended. We just had a shift in White House administration that's going to impact policy in a lot of different areas. Open question to anybody who would like to take it. What do we think we can see and look forward to for the next 4 years under the new administration?
I can kick us off if we want. So one of the nice things that I come back to in these conversations is that behavioral health and SUD issues particularly don't care who you vote for. Often I'm up on the Hill, and one of the common refrains I hear from senators is not a lot of people have my cell phone number, and the folks who do expect to get things done. And one of the few issues that they say, I get calls with people saying, hey, I can't figure this out, is when their kid or their loved one or their partner has an SUD issue, has a behavioral health condition that they can't find treatment for. So this is one of those bipartisan issues that I think we're going to continue to see attention for and continue to see interest in, no matter who's in charge of the White House or Congress.
I just echo just that sentiment of, I think there are very, very few people that want to see people suffer and die, right, around them in their communities and their family. And because, unfortunately, substance use disorder is so widespread, almost everybody has a story, right? And so, in a way that helps with the bipartisan, I think, urgency to address it. I think that my big concern and the thing that keeps me up at night is, can we remove some of the red tape and get there for once? On a lot of these issues that are longstanding ones that have gone through multiple election cycles and haven't been addressed. And I also look at criminality and how we treat our patients and people who use drugs and how that impacts access to care and the stigma around it.
Bless all of you for coming to a panel about policy after being inundated for certainly the last few days, but really quite some time. And just want to ground us all in what really matters to us in this room as change makers and people committed to mission. And certainly for substance use disorder, when we talk about the measure of a society being how we treat our most vulnerable, we're safety net providers. We are seeing patients who are low income, living outside, incarcerated, and they need us. Policy barriers are not new, and the patchwork of local and state and federal policies that govern addiction medicine have been problematic for some time in constraining access to life-saving care. And in the era of fentanyl, where even using one time can be deadly, we do feel a sense of urgency that I think is bipartisan and shared and must cut through some of the noise that we've been hearing over the last couple of days. There's a lot of uncertainty right now, and it's a hard time. So acknowledging that this topic is still raw, I think, coming out of an election and trying to make sense of what's next. But it's so important for us as innovators to be the leaders who are creating the models for change, because government follows what we do. So
That's really well said. Thank you. And let's actually go a little bit into a positive direction. I'd love for each of you to share some of the key regulations from the past few years that have been beneficial to the space, that have, increased funding, increased access to treatment, anything. Yeah.
I'll go ahead and start this one off. So I think everyone here recognizes that when there is a change at the federal level, there has been a period of time, multiple years, that there was a shift and an ask at the ground level. Things don't happen overnight. And so oftentimes what is needed is consistent data and research and evidence to demonstrate to the federal level to make these changes. And some of that is pretty complex, especially when states might have certain regulation that's different from the federal level. But one thing that I have seen that has been very beneficial recently is the shift to embrace finding ways to reimburse for things that are health-related social needs, like housing and nutrition, and things that typically are not reimbursed from a payer standpoint, especially Medicaid. And so embracing these 1115 waivers in different unique ways to ensure that individuals get the services that they need to support their SUD treatment. In the SUD space, there's a lot of need for transportation support. And unfortunately, with unfavorable backgrounds due to criminal activity, at times, housing can be very difficult to obtain. Employment can be very difficult to obtain. So we see states embracing things like North Carolina and even Arizona around SDOH. We see states embracing 1115 waivers focused on criminal legal involvement. We have had a difference across the states when it comes to SDOH, but when it comes to CLI, the criminal legal involvement population, there's a really great opportunity to service not only those that are exiting prison with engaging them with services 90 days before they're leaving, getting medications such as medication-assisted treatment in that process, care management supports, but also it extends to those in the jail population, which are often overlooked, I think, at times because the churn is so quickly, and oftentimes it's not identified through health plans or through behavioral health and physical health providers. But then also these 1115 waivers are embracing youth and supporting those individuals while they are incarcerated. So I think finding creative ways that we can prove out and demonstrate through these waivers that these unique approaches are valuable, and then finding ways to reimburse that through data for consistent, sustainable opportunities is imperative.
Angie, please.
Yeah, I think in the primary care space, one of the shifts we saw was getting rid of the DEA X waiver, the training that doctors needed to be able to prescribe in office-based opioid treatment. And now it's a once and done thing. And so we see more office-based opioid treatment, and so happening in primary care offices. And I think more movement in the primary care space is good, right? Like being able to say to your doctor, you need help, and to be able to get that help, whether it's from suicidality or for, wanting to reduce our drinking or changes in our smoking, and for that doctor to be able to help right then and there, I think is powerful shifts. DEA X-waiver remover was part of that. I think we should keep our eye on the Modernizing Opioid Treatment Access Act, and over time seeing if we can get more shifts in methadone treatment. It's the longest standing, most studied drug we have available, and people need access to it just like they need access to buprenorphine, and we need low barrier access to care. Think about what's happening in North Carolina and Florida with the hurricane. People need access to medication, and it's not sustainable in rural communities to drive 3 hours one way to get access to your daily dose. So we need digital companies like Pursue Care and Boulder Care to stay on the forefront, and for primary care to continue to evolve in this space.
Stephanie, did you have thoughts?
Just echo both comments. I think talking about outcomes-based payment, incredibly impactful when we can align patient success with cost savings and payment reforms, covering SDOH and really innovative but very evidence-based approaches to addiction medicine, including peer recovery specialists, case managers and care navigators, and community integration. So typically under a fee-for-service, a lot of those things wouldn't be covered, and to be able to have the flexibility to innovate and then partner with health plans. Boulder announced our partnership with Centene earlier this month in a paper performance construct, which has been so helpful in moving us all toward those shared goals. And then certainly the XDEA waiver removal in 2023, and for us providing telemedicine care, the flexibilities extended during the COVID-19 pandemic that allowed for the first time for controlled substances like buprenorphine to be prescribed without an in-person visit. That is a big one for not only digital providers, but those in the traditional healthcare system who can have the flexibility to see patients out of a primary care setting or from the emergency department, getting started right away at that urgent moment when someone needs help. Unfortunately, these flexibilities are set to expire at the end of the year if action is not taken. So we've been following closely the support from lawmakers and HHS to come out with a more permanent regulatory framework for digital health. And that, again, is a major barrier to access and an opportunity for us to modernize our healthcare system going forward.
Nick or John, any thoughts?
I got one. So we operate a pharmacy in addition to our virtual treatment, which is a little bit unique in this space and not for the faint of heart. One of the things that we've seen, which is really cool and maybe a little bit off the beaten path, is prisons and corrections actually opening the door for not only prescribing buprenorphine while somebody's on site, right? But also creating, release programs, bridge programs to help them as they're leaving to transition. Because a lot of those folks are leaving without medication, without insurance. We work extensively in Kentucky and West Virginia. We got West Virginia and Kentucky to switch from Vivitrol to buprenorphine because of access issues and just that follow the science and what medication works. And then additionally, Kentucky now allows somebody who is incarcerated to keep their Medicaid coverage so that when they leave, there's not a drop automatically. And that is enormous. People don't understand when you leave and you don't have coverage and you need medication that day and the pharmacy says, well, sorry, tough break, or this is going to cost you a ton of money. You're going back to whatever is going to make you feel not sick, right? Which is usually your drug of choice. So that's something we've seen in the pharmacy time and again, and in some of our virtual health programs, just partnering with prisons and prison treaters.
And I've realized I should not have waited to go last. There are a lot of really good examples up here. I think the piece that I would flag is even more, I think, baseline, and some of the realities that we've seen with the expansion of Medicaid and Medicare to cover MOUD and all three forms, just the reality of where we're at in terms of thinking back to where we were before any of those pieces were able to be covered. I think there's a lot of opportunities there to really make sure that the new Congress and these new conversations as we go forward recognize where we were and where we've come and the value that has really been on the ground.
Got it. And so let's also discuss some of the challenges that, everybody is facing in the treatment community when it comes to either those policies that you were just talking about or other regulations that have come down that have, increased challenges that providers and others face in the space. And also feel free, if you have a solution to any of these challenges, please feel free to share with everybody. And how about we start with Angie and we'll come all the way down.
Oh. Nick looked like he was getting ready to hop off the stage.
Here, can I just say one thing? So Stephanie, let's loosen up. Let's all talk about it. So Stephanie really did a great job of kind of describing this challenge with the waiver, right? And that's a big elephant in the room. What is going to happen? And you see, okay, there was a draft that the DEA advanced internally, but it didn't get out, and there's folks inside the DEA that are against it, and then you hear it's actually more of a politicized issue and not the DEA's fault, and everybody's like doing all of this. And meanwhile, I think, again, Stephanie said it best, is like, as treaters and also patients as consumers, in my opinion, politics should be following the treaters and the patients, and we should be pushing or pulling, in this case, forward. So I think just really focusing in on what is the standard of care, what's supported by the science, allowing doctors and other healthcare providers to lead the way and decide that, and then following their lead. And in many cases, it's removing barriers, not putting new ones in place. And ultimately, if the DEA needs something to enforce on, they're an enforcement agency. Okay, let's figure out something so that they can find bad actors without inhibiting or scaring away providers and patients from both delivering and receiving the care that's so needed.
Thanks, Nick. I think one of the things I see from the clinician-facing side is how creative payers get with the Mental Health and Addictions Parity Act and how they kind of maneuver around that to not give, to deny claims, or to increase co-payments so people can actually afford to come and get their mental health care, or to make the clinician jump through so many hoops to get that reimbursement where they just give up, or to have a network of dead providers. So while we have a Mental Health and Addiction Parity Act, how payers are using that and the creative forces they're maneuvering around that makes it nearly impossible for clinicians on the front line. I hope we see some class action lawsuits in the near future. I don't know, but something's got to give because clinicians are really struggling if they can't get appropriate access to reimbursement.
And I think from the Meadows Institute perspective, because we do so much work with health systems that often work in rural and underserved areas, one of the issues you really see is the need for integration, which has been a through line of this entire conference, that idea that your primary care doc needs to be involved in these conversations. And oftentimes, when we're trying to implement measurement-based care, measurement-informed care, and we're trying to reach some of these communities utilizing telehealth, that any uncertainty, even if you end up coming up with a better idea down the line, just makes it that much more difficult for a small shop, a single shingle provider to really be able to figure out where they need to be. And so making sure the perfect isn't the enemy of the good, and we don't lose some of the momentum that we've had, really seeing a lot of success in rural and underserved communities and getting these resources out there and getting people help and not losing that momentum is probably my biggest concern.
I think a challenge and an opportunity. In partnership with Managed Medicaid MCOs, we've been able to help influence policy at the state level, which really can be as impactful as some of these federal policies when you're on the ground in the day-to-day of healthcare operations. So working with CareSource, for example, being able to talk about the philosophy of care that we're really all very aligned on as a more progressive approach to treatment has been adopted over the last decade. We're understanding more about addictive disease and its treatment, the fact that medication and low barrier harm reduction supports are very effective, introducing new models of care like peer support, being able to come together with the MCOs and say, we all value these things. How do we influence the state to kind of adopt new policies? How do we change our policies as the MCO, dictating the way care is practiced and reimbursed for thousands of people to create change? Of course, the challenge is that every state has its own kind of flavor of regulation, and when you're a newer provider doing telehealth care, a lot of the laws didn't really contemplate this type of care model. So there are hiccups as we're getting reforms, but now has been, I think, a really impactful time, the last few years coming out of COVID, to reopen a lot of the books that have not been touched in decades and be able to rethink the way that we approach a lot of different care, mental health, behavioral services, and addiction. Less like a crime, which is historically how America has treated it, and more like a public health issue, which really reframes the way we talk about solutions.
I'd like to carry forward the topic of peer support for just a moment. And I think one of the positive things that have come out of SUD treatment is embracing the idea of lived experience to the fullest ability. And unfortunately, I think a challenge to that is that there's a lot of variation in the type of service that's offered. There's a lot of variation in the reimbursement rates that are offered. Many of them are not sustainable for an organization to move forward. And so, for instance, in Nevada, for 15 minutes of peer support, it's less than $8 reimbursement. But then you have variation in Alaska. For 15 minutes of peer support is over $23. So there is inconsistency. I think there's inconsistency also in the type of peer support. At the state level, there is identification and embracing of mental health and SUD predominantly. Some states have not gotten to the point of certifying the youth peer supporters or the family peer supporters. And I think there's a real opportunity for us as a nation to grow in that space and to reimburse those services adequately at a sustainable wage, and really value that service. And I want to go back to something that I think Nick had mentioned around data and really using what evidence tells us in the space of some of our MAT prescribing. I think we have to find the balance of between data and also what are the things that we're willing to go out on a ledge for to support because we believe it's the right thing to do, and really embrace those strategies and those approaches as well. Not saying peer support doesn't have evidence, because it does clearly, but I think there's some space that we could really embrace, and a lot of that comes from the community level and identifying some of those solutions there and promoting that and trying to raise the voice of those that are in the community doing the work.
And I just add, it's also low risk, right? It's low risk, low cost in the grand scheme of things. To go out, it shouldn't even be going out on a limb, right? To try that without the data, study it, and yeah, sure, see if there's an impact, and intuitively, or for those in the field, we know there is, right? But we're not talking about high risk interventions or high cost interventions. So much in the paradigm of substance use disorder treatment, it starts at the highest cost and then moves from high acuity down, and that's because we allow people to fall out of healthcare and come back in crisis, and they have to go like this, right? And we have to start trying to open the door with policies and reimbursement structures that allow for more preventive or early stage intervention. And then, I don't know who mentioned, probably everybody, but collaboration, right? And integration to get it into those places where you can have that intervention and you're not going out on a limb, you're saving higher cost care later. We know that, right, in the very least. So let's try some of these things.
That's actually a great segue to the next question, which is about, what are your recommendations for policy that has yet to be enacted? Open-ended question.
So 50 states, 50 sets of regs. Should we go one by one, or? So one thing I would say is there's a lot with telehealth that's held back by some of the old regulations that are on the books for licenses, such as having a physical space. I mean, I'll be the first to admit, like in Kentucky, the inspector general at the time called us and was like, look, Nick, we know that you're propping up this facility just to keep your license, and we're cool with it. And I was like, how about we just change the regulation so we don't have to pay rent for our little ghost facility that confuses everybody, right? So, I mean, right? So it's just, I think we, every state really has to take the time and make it, if it's truly a bipartisan issue, go into the books, go down that list and say, these things don't work for telehealth. Telehealth is a standard of care that's accepted now. It works. Let's make sure that we create either a waiver process or remove it altogether or alter it for the different types of providers providing care. Well, I won't go each state. We could.
Anyone else?
I think one thing that I would just mention is that we have a really great opportunity to see some innovation that could drive and inform regulation and policy change as it relates to the opioid settlement dollars, and seeing some of the creative solutions that are coming across and opportunities tied to grants from some of those dollars. I'm from the state of Ohio, and that's how we have distributed a lot of those funds. And so I think there's, across the board, an opportunity for us to take those learnings and to take some of those creative solutions and be the louder voice to elevate that to the state and the national level. I think we all play a role in advocacy. Sometimes individuals with lived experience do not have a valid seat at the table and a paid seat at the table. I will also say that. And so I think we can grow in that space. It's a solution to inform policy and strategy, as well as providers, ensuring that the feedback from the providers, the concept of all of the paperwork, the red tape that has to be done in order to adhere to some of these regulations, ensuring that that is elevated too. I think that's all within our reach.
I can share a bit of a cautionary tale from Oregon, where we were on the front page news for a while for our experimentation with decriminalizing drug use, and it was, and it is, continues to be difficult. As someone who really embraced the philosophy of the policy, that we would use cannabis tax revenue to help fund treatment programs so that people who were, in possession of small amounts of drugs didn't get saddled with drug charges and then set off the motion of being unable to rent a house or get a job, and just making their substance use disorder that much worse, and instead would have an opportunity to go to treatment. And unfortunately, the experiment ended before it could really begin. Boulder Care was one of the agencies that the state awarded grant funding to be on call for people who needed help. And it was 2.5 years into the implementation of the policy before we received any of that funding. We have the benefit of having other diverse funding sources, but for the majority of providers across the state, they had nothing. And so we decriminalized drugs and didn't give people a link to the care that made that experiment so important. So I share this because I think, as Jess said, we need to be creative and start trying new things. We need to fund programs with opioid settlement dollars and government funding so that we can innovate in this space and really treat this like the crisis that it is. But we also have to stay the course. Execution is not easy. So I am a huge advocate of public-private partnerships that respect the providers and the people with lived experience closest to the ground and give them the funding to really champion a lot of these initiatives and new care delivery models.
John, any thoughts?
I would flag the reality that we all see on the ground is that the need has far outstripped the workforce that we have, that this crisis remains so much bigger than the resources we've been prioritizing to address it. And so opportunities at both the federal and state level to recognize we need to open up the workforce, reduce the sort of unnecessary licensing restrictions that really prevent people from engaging, increase reimbursement, and really leverage integration wherever possible. I think there's a number of bills up on the federal level to really incentivize integration and prioritize things like collaborative care and bringing those opportunities for primary care docs to really be involved in this conversation. Those pieces, I think, the urgency of making sure that we have a workforce that can provide this care has not really been commensurate with the sort of recognition at the regulatory level of what the urgency is.
Yeah, I agree with all of those things. I think the only thing I can add to this is I would like to see continued traction with the discussion around recovery-friendly workplaces and see regulations and federal policies that align with that, training HRs and companies to treat this like a public health crisis that we're all kind of facing. Mental health, substance use disorder impacts every single one of us in here, and that impacts our workforce, and that impacts us at work. The other thing that I think is kind of interesting is if you've ever taken your loved one to get care, and let's say what they're struggling with is a mental health crisis at the point, but they discover a substance use disorder underneath that when they do screening, and they deny services because there's a substance use disorder on board. Or you could just flip that story, right? The ASAM criteria that was put out in November of 2024, the new criteria said, all systems need to be co-occurring capable. So at a baseline, if you walk into a primary care office, an emergency room department, in the near future to get reimbursement at any of their levels of care, they need to be able to treat mental health and substance use disorder at a baseline, depression, anxiety, mood disorders. But for the expanded care, for the higher levels of care, more higher level schizophrenia, more higher level mood disorders, right? They're gonna go into higher levels of care. So I would like to see regulations that can align systems and penalize systems that aren't providing co-occurring capable care, meaning we're not denying somebody a service because they have either a substance use disorder or a mental health condition on board, that we can treat that at a capable level, and that we're training and we're doing our part to train our workforce to do so. And if they're not, there are penalties on systems that aren't doing that. And for those for needing higher levels of care, for the ASAM criteria, that those doors are open for them to receive that as well, and we have a trained workforce to respond. It's no longer about treating just the substance use or just the mental health. We're going to go ahead and say that it's likely if one of those is on board that we've got both of those on board, whether the person is aware of it or not. So I'd like to see some regulations that align with co-occurring capabilities and make that mandated.
Thank you. So we actually have another question or two, but the Apple product is not working. So does anybody have a question that they wanted to ask, and we can just gauge whether we want to go to the audience or continue with ours? Any hands? Yes? Okay, go ahead.
Can you hear me? First of all, I want to thank all of you for being here. And I loved that you brought up Oregon's experiment with decriminalizing drugs. And I think I heard you say the lesson learned, but do you see a path for someone else trying this or Oregon trying it again? And for those of us in the room who would like to pave the way to re-experiment, what would you recommend?
I think the sentiments behind the policy, kind of compassionate treatment, the links to getting people into care and protecting people from the harms of the justice system, there is still quite a bit of support for that. Decriminalization as a policy, I think, is a bit challenging, and there has been a bit of a re-stigmatization, I would say. As coming out of COVID, some of our cities and rural towns alike have been hit hard by fentanyl. In some cases, that intersects with a housing crisis, as it does in Portland, where I live. And so suffering is very visible, and it has made it really challenging to embrace some of the harm reduction principles and the patience, I think, and being able to help people get into care when they're ready that are important. What we focus on at Boulder Care is low threshold and immediately accessible treatment, and I think that is pretty uncontroversial. To be able to give someone a link to care when they're ready and say within 40 minutes you can get access to your medication and not jump through a bunch of hoops, to partner with justice systems and drug courts so that we can try to expunge criminal records and help people get into transitional programs or housing. These are all really important strategies, and over time, I think the data will show that this approach is the right thing, both for public health and our economics as well, when people aren't flying through the emergency department 25 times in a year, or like some of the patients that we serve, forced out of housing because they're taking medication that's saving their lives in previous care settings. There's so much we need to do to align the evidence with practices. And so I am a huge believer that we are making progress in that direction. But some of the language we use has to change, I think, in order to avoid the controversy that's been surrounding this decriminalization policy. And I would also add that harm reduction in many towns is still, vastly underfunded and even illegal. So in many parts of our country, you can't give someone fentanyl testing strips to ensure that their drugs aren't laced with fentanyl unknowingly. And that is a real tragedy when we think about the practical realities of people who are going to be using drugs, and for them to do that more safely means we save lives. But it has been really heartening to see the adoption of naloxone or Narcan, the overdose reversal drug, and that becoming an over-the-counter medication in recent years. So getting utilization of that up is another really important part of the overall strategy.
And really quick before we go to the next question, John, as our resident policy man, I'd love to hear your thoughts and kind of what you guys are doing, at the Institute, or what you're paying attention to. Is there any talk about Oregon and decriminalization in general?
I think at the federal level there's and I think we're seeing this conversation broadly, trying to figure out what works. And I think there is a real interest from policymakers in understanding the science and understanding the realities of what needs to happen. And I think that's obviously a complicated conversation to have, and to sort of bust through some of the myths and make sure everyone understands the issue. But I think one of the biggest things that I would encourage everyone to do is what we talked about a little bit earlier, is really making sure that we're breaking down the silos in these conversations. One of the biggest concerns I see is that you'll have sort of SUD conversations and mental health conversations, and then law enforcement conversations, and those groups never talk to each other, and a policymaker is hearing from 3 different groups about the same issue and has to pick and choose. And I think that's a real concern, particularly in these situations where there is a lot of confusion about what the right answer is. And so being able to go in with one clear message and one answer makes things that much easier, because they're just so busy and have so many issues to cover.
Thank you. Go ahead.
Thank you all so much for the excellent panel. My name is Marlena Lira. I'm a researcher at Work at Health and a big fan of all of you. I'm curious if any of you could speak to buprenorphine access issues in pharmacies, which, as far as I'm aware, are kind of an unintended side effect of the opioid settlement agreements. And kind of as a follow-up, if any of you are familiar with San Francisco Department of Health's new county ordinance, city ordinance requiring pharmacies to stock enough buprenorphine so 2 people can start at any time, and other kind of policy solutions to those issues.
So that's an awesome policy. I would love to see that everywhere. Yeah, so without starting a new session, the challenge from the pharmacy perspective is, with the opioid settlements, increased risk and compliance pressure on the distributors, and they still treat buprenorphine as a class 3 narcotic opioid, right? And pharmacies are expected to comply with ratios for the amount of those medications dispensed versus other meds. So for our pharmacy, of course, we are like a red flag through the roof because we're doing tons and tons of buprenorphine and other medications like that, right? And so it's a ongoing challenge. We have great relationships with our distributors. We love our distributors. We want to stay friends, but they have pressure on them from the DEA and others, and it makes it very hard for them to, like we don't fit in their ecosystem. The other thing I would add is, so roughly our numbers are that roughly 75% of pharmacies, retail and otherwise, do not carry buprenorphine in stock. They won't say that it's their policy, but on the ground, especially in retail pharmacies, pharmacists, they have a ton of pressure on them. It's one pharmacist and they're trying to it's volume, right? Fast. And when one of our patients comes in, they're concerned that they can't provide adequate pharmacotherapy to help to advise that patient, and it becomes a risk issue in their pharmacy. And so they just don't do it, right? And the consequence of that, along with the telemedicine thing, right, is those scripts don't get filled. And that's part of why we have a pharmacy, but, we just need more what you just described, which is like clear policies that say, hey, this is okay. We're going to accept this out of the rest of the things that are more risky, like the Schedule 2s.
Anyone else? Any thoughts?
Just echo, it's absolutely an issue, and appreciate the question and all of the advocacy and research work around this topic as well. The empathy for the average pharmacist who is working very long shifts with very few resources, and we do a lot of work in Ohio, for example, where the big box pharmacies are acquiring some of the mom and pops and then just closing them down. And so for miles, there are folks without a pharmacist, and there's not only a very busy workflow for those folks filling prescriptions, there is the liability that has been kind of imposed on them, the same crackdown on opioid overprescribing. There's too much OxyContin and we should sue Walmart and Rite Aid and these other pharmacists for their role in it. They're now being told, take a conservative approach and don't fill the treatment for addiction, which is really getting us into a paradoxical, poor situation on the ground. And so we found that partnering with pharmacies and kind of making it known who we are as an organization, having a conversation with medical director to pharmacists about our protocols and why telehealth and buprenorphine prescribing looks the way it does is useful, but there's just so little time. And the healthcare system is under the strain of so much weight. So primary care, pharmacists, others, it's just as Nick said, the default is just do nothing, and you're...
Well, and you want... patient choice is important. Like, we can't and we don't want to tell every patient, sorry, we just can't get your script filled locally, so it's going to have to be shipped to you, and you're going to have to be home, and you got to sign for it. Those are the challenges of how we operate in our pharmacy, and sometimes a patient needs medication right then and there. And so that's the real impact on the ground that we see all the time, is a patient wants to be able to walk into the pharmacy right around the corner and be able to walk out with medication, and they can't. And the risk on the pharmacy side, you kind of understand with how they look at the PDMP and the pressure they have on them. So I think it's just we have to create a policy that creates a clear path for this, so that it de-risks it and everybody goes, okay, this is for treatment, it's safe, let's make sure that we're well stocked and we can serve that need.
And DEA, to their credit, actually came out with a formal memo saying,
did, yeah.
We think you should be filling these prescriptions, and the COVID flexibilities also permit it over telehealth, but it had very little impact.
No.
You really need a permanent policy and full-throated support from all levels of government to
the state level,
trickle down to practice.
The state level and the state boards of pharmacy. I mean, we had to go under consent with the Board of Pharmacy in West Virginia because we got a complaint from an outside prescriber that a patient had traveled 2 hours to get to our pharmacy, and the Board of Pharmacy considered that a red flag. And they gave us, there was no penalty, no fine, just don't do that. And what's the reason? Because the person had to drive 2 hours to find a pharmacy to fill the script, which it's just wild.
Thank you, everybody. We're actually at time, but I do encourage you to come and ask the question directly to them. Thank you so much, everybody, for joining the session, and to our panelists.